Good evening and welcome to blackdoctor.org. I'm your host, Shamika Rhymes, and we're so glad you're joining us here tonight. Let me know where you guys are watching from. Drop that in the chat. And so November is National Epilepsy Awareness Month. So tonight we're going to take a deeper look at epilepsy with an expert panel of doctors who are here to answer your questions. So again, make sure you drop your questions in the chat tonight. We're going to talk about the facts, debunk myths, and talk about how epilepsy affects the brain, the challenges of diagnosis, treatment options, and unique experiences in the Black community. So again, make sure you drop your questions in the chat. Let's see, we've got some people popping up in the chat already. Thank you, Alabama, for joining us. Let me know where you guys are watching from. Let me introduce you to our panelists tonight. So we have Dr. Crystal Hall. She's the Regional Director of East Operations for the Epilepsy Foundation of America. Welcome. Dr. Deborah Holder. She's the Program Director of Pediatric Epilepsy at Cedars-Sinai. Welcome. And Dr. Lisa Bateman, a neurologist at Cedars-Sinai. Welcome to all of you. How are you?
Thank you. Doing well.
Great. Thanks for having us.
Thank you for having me.
So let's start it off, and I'll start with you, Dr. Bateman. What exactly is epilepsy and how does it affect the brain?
Great question. So epilepsy is basically a condition that is characterized by the tendency to have seizures. More than one seizure, and seizures that aren't typically provoked by anything obvious. So anyone could have a seizure under the wrong circumstances, but for people with epilepsy, they have these recurrent unprovoked events come out of the blue without obvious reason to cause them. Seizures can take a lot of different forms, and I think we'll get into that a little bit later, and can impact people in a lot of different ways. And we have a lot of different considerations for how the brain is impacted by seizures in the young developing brain, in the pediatric population, like Dr. Holder sees, and then the impacts in the adult population, who are more the type of people that I see.
Okay. Dr. Holder, did you want to add anything about epilepsy and how it affects the brain, especially in children?
Yeah, sure. So when we treat seizures in the pediatric population, I think we're maybe a little more aggressive, just because when we're dealing with seizures in children, kids are different in that adults, we already know how to learn. Our brains already fully accomplished that goal, but children, they haven't learned that yet. Their brain's still developing and they haven't fully learned how to think and process information. And we know that when kids are having seizures, it can impact their ability to think and learn and process information. So we're really kind of under the gun. We really want to treat seizures quickly and do our best to get seizures under complete control if possible, so that the brain can fully develop and kids can really meet their full potential. So we try treatments maybe a little more quickly. We move from one treatment to the next a little more quickly, and we may move on to other treatment options other than medications a little more quickly, because we feel like we always have that ticking time clock in our back of our head, knowing that we have this limited time frame between when we have the ability to get the brain to really reach its full developmental goals. And we want to make sure that all of our kids get to their full potential. So we really want to be a little more aggressive and really make sure that we don't drop the ball, that we really give our patients their best ability to achieve their ultimate, best outcomes.
Okay, thank you. And this can go to really anybody. Can you describe the different types of seizures that someone might experience? We can start with Dr. Bateman and then go around.
Sure. The way I often explain it to people is that any type of experience that your brain can create, it can make a seizure out of. So depending on where a seizure originates or spreads to in your brain, if you have a seizure that involves, the part of your brain that controls your vision, you could have changes in your vision. If you have a seizure in the part of your brain that controls your movement, you can have trouble moving or uncontrolled movements. Some people will have seizures that impair their consciousness, so they're not able to react or respond to things that happen in the environment around them. And some people may have seizures where they fall, injure themselves, and what we think of as sort of the classic TV kind of seizure that everyone thinks of when they think of the word seizure, people who have sort of full body convulsions as part of the seizure. But seizures may be very, very subtle, or they may be quite obvious to people around the person having them.
Okay. Dr. Holder?
Oh,
There you go.
no worries. Thank you. I would agree. So when I talk to families about seizures and epilepsy, we kind of group seizures into two big categories. We have focal seizures, like Dr. Bateman talked about, where seizures start in one area in the brain and then spread. And those seizures, as she said, can really look like anything depending on what area in the brain the seizure started in. So whether it's in the vision area or the language area, or whether you may just have staring and be unresponsive for a few seconds, they can be very subtle. I usually tell families, if you notice any funny spell that happens more than once, you have to think that could be a seizure, because it really can be. Any funny thing a patient does or a kiddo does, if it happens more than once, seizure should be on the differential. And then we have generalized seizures where it looks like the whole brain fires at once. And those are often the bigger seizures that people are more used to thinking about, where there may be loss of consciousness and the whole body kind of getting stiff or shaking. Those are the seizures that more people are familiar with, but it's those smaller, more subtle seizures that are actually more common. And the more ones that we see more often, but those are also the ones people aren't as familiar with, and they're often missed because people aren't thinking when the kiddo just stops and stares and maybe has eye fluttering for 3 seconds. People aren't thinking, oh, that's a seizure. They just think, oh, that child's not listening to me when I call their name and ask them a question. So often those kids get misdiagnosed with ADD or ADHD, or they're just called bad kids, and they're not bad kids. They're kids having seizures. And those are the kids we need to get into our offices, because it takes them a long time to get to doctors like us because they're often misdiagnosed. So we like to think that if someone's having any funny spell where the same kind of unusual or odd or odd character behavior happens more than once, we need to be thinking seizure, we need to be thinking neurologist, and we need to be thinking get a brainwave test or an EEG so we can make sure we're not missing seizures that can be easily treated, and we can get those kiddos back on track and make sure they're getting the treatment that they need.
Okay, thank you. Crystal, is there anything you wanted to add?
Yeah, I agree. As a former educator, missing those marks of thinking my students were just daydreaming, or, telling the parents that something's going on and they're like, oh, they have ADD or ADHD. And I'm like, I'm not so sure. But there's also one that I also didn't know, which is the sensory disturbances, like smelling something that like fire, or the sense of paranoia or anxiety, or tingling sensations and things like that, that we just kind of brush off and go on about our business. And then we have it, or those feelings of deja vu that could be something could be a seizure as well.
Wow. Okay.
Sorry.
Go ahead.
we do see, analogous to what Crystal and Deb are saying, similar things in the adult population. When someone comes in and they're fainting or blacking out or having funny spells, or having episodes with anxiety or fear, they will often get diagnosed as cardiac heart type of events, or strokes or mini strokes, especially if they're older, or even, as having some kind of psychiatric disturbance like a panic attack or an anxiety disorder, rather than the episodes actually being recognized as a seizure.
Wow. Okay. Crystal, let me jump to this question. Why is epilepsy often misunderstood in the Black community? And I'm sure some are wondering if it's genetic or hereditary as well. And that may be a question for the other two doctors to bring in their expertise on that part too. But yeah.
Yes, I'll let them talk about the genetic part of it. But in the Black community, to be honest, sometimes it's the wording. It's what we have learned and been taught over circumstances in life. We've heard them be called spells. And when we think about spells, we think about witchcraft or something demonic, or they're called fits and things like that. And growing up, what goes on in the household, you stay in the household, you don't really talk about it. And so even for my family, or even I do have a sister living with epilepsy. And so we didn't recognize when she started having seizures, they were saying she was passing out, and so they didn't recognize them as seizures. It was a passing out kind of thing. And because we don't talk about it, and, you learn later on, like, oh, such and such had it, or such and such had it, but we never shared it. And so those things that we didn't share, we don't know.
Right.
that's part of it. And I think we just learn. I mean, I could go on and on about that, but we've heard them about being demonic, or I could be contagious. Those things that we learned, or I have, I'm crazy. I'm those mental health, because in the past, when they first started talking about epilepsy, they were put into a mental health asylum, things like that. And so those are just things that we don't talk about and we don't share, because we don't want people to say that we're crazy.
Yeah, that makes so much sense. And I was just thinking, as you were talking about it, thinking of all the TV shows and movies where you see that. And so and of course it's a dramatized way of, for movies or TV, and it's entertainment, but you start to think, well, that person was possessed on there, so maybe that's the same thing. So yeah, I totally get it. Now, so the other part of that question was if this is genetic or hereditary. Would either of the doctors like to weigh in on that?
Yeah, I can take that. So actually it's an interesting question. And I think we've gotten a lot smarter about the genetics of epilepsy over the last 10 years. There actually is a big genetic link with epilepsy, but it's a little different than how we typically think about genetics. We've found over 600 genes that are associated with epilepsy, but most genetics of epilepsy is not inherited. So it's actually not inherited from your parents to the child or to the person with epilepsy. The genetics that causes the epilepsy usually happens for the first time in the patient who has epilepsy. So it's what we call de novo. So it's funny because a lot of people, I think when I start talking to a family about wanting to do genetic testing and wanting to get genetics done, they say, well, no one else in the family has epilepsy. Why do you want to do that? And it's because genetics of epilepsy is a little different. And usually it happens for the first time in that patient with epilepsy. So there may not be any family history of epilepsy in the family, but we still may find a genetic cause for that individual patient. And that can be really helpful. If we find a genetic answer, it may help us pick the right medication. It may help us tell what medication not to use. May help us with other treatment options that may work well for that patient. It may help us know if other organs are going to be involved in the future. And that particular person with the genetic epilepsy may then also be able to pass that down to their children in the future. So it may be relevant for other family members. There are a few genetic epilepsies that are inherited from family members. So there are some families where epilepsy does run in the family, but by far the most of them are not familial, don't run in the families. But it is very important. Everybody who has epilepsy should have genetic testing. And we're now in the pediatric field, we're now testing patients after their first seizure. So it's very important and very relevant. And back to what you were talking about before, I think the stigma for epilepsy actually goes across all nationalities and all races and all patients. And the stigma for epilepsy is actually quite significant. I think a lot of diseases have been able to overcome their stigma and are now being readily talked about. And that's really helped raise awareness and raise funds and increase research. And epilepsy, we just haven't made it. We still have a really significant stigma. And most of our families, the patients don't talk about it. They're afraid that if they have a seizure at school, what the kids will think. And the parents don't talk about it. And I'm at an epilepsy advocacy event right now that we're doing down in Orange County, and we've got thousands of epilepsy patients here learning about epilepsy and trying to increase awareness and advocacy. But it's really we have an uphill climb, I think, for our community to really get people willing to talk about epilepsy. And there's 1 in 26 Americans has epilepsy, so really probably everybody knows somebody with epilepsy, but you don't realize you know somebody with epilepsy because that person's not talking about their epilepsy. And I think the more we all feel open to share our stories and talk about it, the more we can help decrease that stigma and make everybody more comfortable sharing their stories so that we can help everybody reach out and get the treatment that they really deserve.
Absolutely. That's great insight. Thank you. Dr. Bateman, did you want to add anything?
Yeah, I cannot agree with Dr. Holder more on this. It's a huge issue for our community. There is a lot of stigma. It goes back to some of the things Dr. Hall was saying about, epilepsy being demonic possession, being, some punishment for a prior sin or a mental health issue. People with epilepsy were not able to get married in certain states in the US up until the 80s and were involuntarily sterilized. There's this whole stigma about people being in contact with individuals with epilepsy because it might be contagious. So parents won't allow their kids to play with someone with epilepsy, or people don't want to be in a relationship with someone with epilepsy, never mind the strain of being the person with the condition and having to decide who you disclose it and when. There's also other huge impacts in terms of just getting around society as a human that we'll probably talk about a little more later on. But it's the stigma is real, and we really have not been able to totally defeat that.
Dr. Holder, you just mentioned this a second ago, so I wanted to go back to it about testing. You mentioned that sometimes you can diagnose as like literally as soon as the first seizure has happened. How important is early diagnosis, and what tests are involved for diagnosis?
Yeah, that's a great question. So, I'm a big advocate of early diagnosis and early testing, but as you see, sometimes it's a bit of an uphill battle because often the patients themselves don't even know they're having seizures. So it's really a lot of advocacy work and networking with our pediatricians and our primary care teachers, our primary care folks, and even the teachers, as you mentioned. Most of our kids spend most of their days at school, so really educating our teachers to be aware of what's going on. So we've started a lot of what we call nuanced seizure clinics. And our goal is to get kids into a clinic within a week or days of their either their big seizure or their funny spells, or whenever someone identifies something's going on that just isn't right, and we want to know what that is. So our goal is to get those kiddos into a clinic with a neurologist, a specialist in epilepsy, within a week to 10 days of their event or whatever's been identified. And as well as seeing that specialist, a doctor who's an expert in epilepsy, we also want a brainwave test, which is an EEG. So an EEG is a brainwave test where we put little stickers on the outside of the head. It's a very non-invasive study, and we just look at the brainwaves. We let the child or the adult patient, be awake and asleep. It takes about an hour, and that test can give us a lot of information if the patient has a seizure, at risk to have seizures, and often with that information, just the history and the physical and the information from the patient and their family and the brainwave test, we can often make the diagnosis and see if the cell was a seizure, if they're at risk for more seizures, and help us determine if we need to do any other testing. In pediatrics, we often, if we think it was a seizure the patient had, we often will do our genetic testing at that point as well.
Okay, thank you. Dr. Bateman, can you talk a little bit about testing adults?
Yeah, I think the testing is quite similar. We basically, when we see someone's having seizures, we want to know two things. Seizures originate from the brain, so we want to know what the electrical activity of the brain looks like. So with an EEG test, much like Dr. Holder just described. And the other thing we want to look at, and this will apply to Dr. Holder's population as well, is what the brain physically looks like. So is there something structural within the brain that would explain why the person is having seizures? We usually do that with a brain imaging study, an MRI study. And for individuals who have seizures, we often like to do the MRI in a particular way, look at the brain in 3 dimensions and very specific ways that we analyze the brain images, just to try and find any small, subtle, little something within an individual's brain that might be a cause for them to have seizures.
Okay. Are there some common triggers for seizures? And if so, how can they be avoided?
Yeah, I think there are many, and probably some of them are a little different on the adult side than on the pediatric side. People who are prone to seizures can be quite sensitive to being sleep deprived, overtired. That may make the brain more irritable. When people are sick and they have infections, for example, or they get a high fever, which I think Dr. Holder can speak to a little bit more, they may be more likely to have a seizure. Drugs, alcohol, and other sort of substances and metabolic issues can trigger seizures for some people. And for really someone who's already been diagnosed with seizures and is supposed to be taking seizure medication, the number one reason they may have another seizure is that they've missed a dose of their medication or multiple doses of their medication, or they're not taking their medication properly. Now, there can be lots of reasons for that, but that's kind of a number one trigger for us. Some other people may be sensitive to lights. Many people will kind of hear about, oh yeah, flashing white lights trigger my seizures. And that is true for a certain group of people with epilepsy. Some people will have very kind of random, typical for them kind of triggers that may or may not affect other people. And of course, the one thing we hear over and over again, like with most other things, people with epilepsy or with seizures will say that stress is a trigger for seizures for them.
Okay, thank you. Dr. Holder, in the pediatric population, what are some common triggers?
Yeah, so good question. And I agree with everything Dr. Bateman said. I think that in the pediatric population, the most common thing we see is fever. So we have febrile seizures, which is a type of epilepsy that we see in young children. So fever is probably one of the most common. And then I usually tell families any stress on the body. The funny thing about the body is it interprets all stress the same. So both good stress and bad stress. Unfortunately, I've had kiddos seize on Christmas morning because they're excited, or, we live here in Southern California, so they go to Disneyland and they get so excited about being there, they unfortunately have seizures. So we want to try to moderate stress the best we can. You can't get rid of all stress because you have to live in the world, but we want to try to keep stress as manageable as possible. We have kids who seize around exam time because of, exams, but that doesn't do any good because we have to try to manage stress so we can get through life. So we work on that. We work hard on ways to try to manage stress, trying to do things that help eliminate stress for each individual patient, and really try to work hard on that. And then any stress on the body, like an infection, being sick, lack of sleep is a big trigger, as Dr. Bateman said. Luckily, our little kiddos aren't doing the things that our young adults are doing, so I don't have to worry as much about that. So mostly the kind of common things that get into kids' lives, and fevers, infections, and then stress. So we just work with our families. We do pretty good. It's interesting when you look at compliance. Compliance is really a challenge for everybody. We think we did a study years ago at one of my previous jobs where we looked at compliance in the pediatric population. So you look at parents who were just told their children have epilepsy and they now need to be on a medication. And you look to see how compliant that population of patients are. You think this is going to be the most compliant population. You just told a parent that their child has seizures and they need to give them medication every day to prevent another seizure from happening. And in that population of patients, compliance was only 50%. So you think if the parents of newly diagnosed children give medication the first 6 months after being diagnosed, their medication is 50%. You can imagine how challenging it is for our young adults and our teenagers and people living active, busy lives. So compliance is a challenge. We need to really do our best to try to make it as easy for our patients as possible. Use medications that maybe are given once a day instead of twice a day, or medications that are a little bit easier on our families to take, and really try to work with our patients and see what the challenges are to getting their medications on a daily basis and see how we can help them. It's really hard to take medication every day. I think we don't think about that a lot, but it really can be challenging, and we really need to try to help our patients so they can be successful.
There was a question in the comments for you, Dr. Holder. Melissa says, if a child has, did you say it, febrile? Is that how you pronounce it? Febrile induced seizure, are they more susceptible to epilepsy?
That's a good question. So most of the time they're not. So there's different types of febrile seizures. There's a simple febrile seizure where the seizure is short. They only have 1 in 24 hours, and the seizure itself was what we call generalized. And those patients actually don't have a higher risk of epilepsy. So it's only if the febrile seizure is what we call complicated, where it's very long, or if they have multiple seizures in a 24-hour period, or the seizure was focal. And then those patients have just a slightly higher risk of going on and have epilepsy. So most of the time, febrile seizures are actually not anything that we worry too much about. It's a very common condition. We see lots of kiddos who have them, and most of the time, those children do not go on and have epilepsy.
Okay, thank you. Crystal, how does stigma that we were talking about earlier impact individuals living with epilepsy and their families? And I think this is a good time to probably look at the mental health aspect as well, like how that impacts the individual and the family.
And so it impacts the whole family. And I think we sometimes kind of forget about the caregivers who have to actually see the child or the loved one having the seizures and having to live it over and over and over again as they see it. It impacts them by the stigma where if they're in working age, they don't want to share because they don't want to get fired from their job or told that they're a liability. We've heard stories about people having a seizure and then the next at their job, and then the next thing they know, they're fired because, oh, you can't have a seizure on our property. It's a liability. If you are having active seizures in most states, you can't drive. So if you can't drive, you can't work. Nobody really wants to be around you to play or to know or to help you understand. So you can't really have that productive life. Sometimes the medication, depending on what it is, it does reduce your life, I'm missing the word right now, but that longevity of life, of living, sometimes it decreases your stamina, you're fatigued a little bit more. Or if you're having seizures at night, then that morning you're tired and you don't want to go to school, you don't want to go out and do things. And so all together you're having it. And then as a parent or a loved one, you're hearing those stories of what did you do? Why is your child having seizures? What did you do? What did you do in your lifespan to have to deal with this now? You need to go and repent, or you need to go and figure it out, those types of conversations. So then you keep it into yourself. And then you're thinking about that whole mental health aspect. We know that 40 to 50% of people diagnosed with epilepsy, they have a higher rate of suicide ideation or committing suicide because of all of the mental health. We also know that there's 30% that will have depression and 40% that will have anxiety. And even with the parents and the caregivers, there's 40% that will have insomnia because of just staying up overnight or not being able to sleep, worried about their child having a seizure during the night and them not being there. So it's a lot of that impacts. I just did a study on this, and we actually just had a Women in Epilepsy brunch that talked about mental health and the self-care and making sure that you're taking care of yourself and you're putting some ideas in to take care of yourself, to make sure that your spirit, your mind, your body is doing okay while you're in there. But one of the things that I found was that it said that 1/4 of people who already have mental health issues will be diagnosed with epilepsy. And so it's just one of those things where you're like, wow, what do you do then as coming in, making sure that those mental health issues are taken care of, or the resources are given to them on impact, on diagnosis, so that we can reduce those types of things.
Okay. That actually leads into a question in the comments. And this is for probably Dr. Bateman. Darylyn Coate, sorry if I'm pronouncing your name wrong, is asking if there is a proven scientific link between dementia and seizures in a person with adult onset epilepsy. It says in parentheses, the time where the patient goes absent and has continued to have seizures for over 15 years that are getting more frequent or at mid-70s.
Yeah, so this is an important question, and there's a few sides to it. One is that as people do get older, there is an increased incidence of memory loss, even without epilepsy. And so dementia becomes more likely as we all get older. That doesn't mean, of course, that we're all going to suffer from it, but there is an increased risk of epilepsy developing in individuals with dementia. And when we look at people who have epilepsy, there is also a certain proportion of people with epilepsy who will develop problems with their memory over time and may eventually come to meet criteria for dementia. We know certainly that there is an impact of repeated seizures on the brain. Dr. Holder has alluded to that in the developing brain. If your brain can't learn, you're going to be impacted when you're young. And similarly, if you are having repeated seizures as an adult, that can cause problems as well. It is incredibly common for people with epilepsy and seizures to complain about issues with their memory. Some of that has to do with the impact of a seizure. So if you're out, you don't know what's going on. So how can you remember it later if it doesn't get into your brain in the first place? Often parts of the brain that are important in memory can be the very parts of the brain that generate seizures. So if this part of your brain is busy making a seizure, doing something that it's not supposed to be doing, then it's hard for it to do what it's supposed to be doing. And then there's also an impact of medications. We've already talked a little bit about how medications can make you feel slowed down, sluggish. They can also impact your thinking, and some of our seizure medications are kind of notorious for causing people to have memory problems or trouble coming up with words and names for things and that kind of thing. So memory issues are common for people with epilepsy, and it can be very complex to try to tease out what the causes are.
Well, that brings me to my next question. What are some common treatments and how effective are they?
So I think we are fortunate that for many people, probably about 2/3 or so who are living with epilepsy, they can have their seizures well controlled with anti-seizure medications. And we have over 30 of those available now. Choices that we can tailor to a person's particular life situation, other medical issues they may have, the type of epilepsy they may have, and so on. And so that is hopefully the expectation when someone begins their epilepsy journey, that their seizures will be controlled with medication. However, we do know and have known for a long time, despite developing 20 plus new medications over the last 20 or so years, that there are a proportion of people whose seizures will not be controlled with whatever medication they use. And those people may be candidates for other treatments for their epilepsy, different types of surgical procedures, diet therapies, other types of interventions that may be more efficacious for them than medications. One thing that's really important is that we can tell when a person's not going to have their seizures well controlled with medicines, usually after they fail the second medicine. About half of people would respond to the first medicine they try, and then another 10 or 20% to the second or third. So you do not have to go through all 30 medicines, all in different combinations. That would take billions of years. And in the meantime, you're living with uncontrolled seizures. So for anyone who has not had their seizures respond to two different types of medications, they should definitely seek out an epilepsy specialist so they can have further evaluation for other types of treatments that may be appropriate for them. Also, to make sure that they actually do have epilepsy and that we're treating what we think we're treating. Because as we said, sometimes seizures are mistaken for other things. Sometimes other type of events and other medical conditions are also mistaken for seizures.
Can you, and I know there's probably like several, but I'm just curious as to which ones get misdiagnosed for epilepsy or the other way around.
Right. So we talked about a few of them, or I did anyway, when we were talking about things that epilepsy gets mistaken for. So seizures, problems with the heart. So if you get a funny feeling in your chest and you black out, that could be a seizure, but it could also be a problem with your heart. And what you need is a pacemaker and not epilepsy medicine. Other blood vessel problems within the brain. Sometimes people may have very unusual symptoms or even convulsions related to migraine headaches, which is more related to kind of blood flow and nerve issues within the brain. And then sometimes people do actually have symptoms that are more related to an underlying psychiatric condition or stress that does manifest itself physically as a seizure. And for lack of better terms, we sort of call those non-epileptic seizures or non-epileptic episodes. Okay. It's important to sort those things out because then the person can receive appropriate treatment and not keep cycling through medications that aren't going to work and potentially cause side effects.
Okay, thank you. Dr. Holder, what are some common treatment options for the kids?
Yeah, so interestingly, we treat kids very similarly to adults. There maybe are some different medication options that we choose because there are some slightly different epilepsy syndromes that we see in children, but we do things very similarly. And interestingly, the statistics are also very similar. We end up with about 2/3 of our children being able to be controlled on medication. I think the one thing that's kind of nice in the pediatric population is we have a large group of pediatric epilepsy syndromes where the children outgrow their epilepsy and the seizures go away with time. So unfortunately, that's not something that you see as much on the adult side. So we have a group of kids where we treat them, and they have these epilepsy types that we call self-limited epilepsy, where we treat them and over time their seizures go away. And they're not going to have lifelong epilepsy. Their seizures are going to go away as they hit puberty. It really doesn't matter what I do as a doctor, as long as, you know, their brain continues to grow and mature, their seizures go away. So that's one group of patient population where things go really well. Then we do the same thing as long as the seizures are not controlled with the first or second medication. We do the evaluation, just like Dr. Bateman said, and we work the patients up for other treatment options, which include things like surgery. We have a number of implantable devices we use, and I think we do excuse me, we do a little more diet therapy in children than they do in adults. And diet therapy can be very effective. We use a high-fat, low-carb diet. The most commonly used one is called ketogenic diet, but we also use a variation of that called modified Atkins diet, which is a little less strict. And what we do is we put the brain into ketosis, where the brain is using a breakdown product of fat called ketones, and that allows patients to have seizure control just by modifying how they eat. So we use a lot of different things when medications aren't effective. I agree with Dr. Bateman. The most important thing for people to know is if you've been treated with epilepsy and don't have seizure control after 2 medications, you really need to seek out an epilepsy expert. And in some places, that means traveling to another state. There are some places where there aren't pediatric epilepsy experts even in the state. And you often have to go to the big city, but in some places you actually have to travel to another state because there's not, especially for pediatrics, there's not enough of us. There's not places where there aren't pediatric epilepsy experts, but you need to do it because you may miss a treatment that could actually cure your epilepsy, and you don't want to let that happen. So you really have to seek out that expertise, at least for a one-time evaluation, to make sure you have the right diagnosis and you're getting the right treatment.
Thank you. I was just wondering, Crystal, if people can contact your foundation to say, hey, can you help me find, the right specialist?
Yes, we have a 1-800 help. Can you hear me?
Yes.
Okay. We have a 1-800 helpline that we can send you to the different level 4 treatment centers within the states to let you know where they are and things like that. And most of us have board members and medical professional advisory boards that we can go to and say, hey, do you have some openings, things like that too. So we those are always there. We know them. We stay up on the level 4 treatment centers and things like that as well.
Okay. Well, while I have you, Crystal, how can someone develop a seizure action plan, and why is that so important?
So seizure action plan is very, very important. And a lot of times we just talk about it with children, but when I do the trainings and stuff, I talk about adults need them too. That seizure action plan gathers all the information about that person and about their seizures, if they have rescue meds, when it becomes an emergency for them, when it's necessary to call 911, what emergency person. And those seizure action plans are made with the caregivers, as long as not the caregiver, but the care team, their medical professional, their neurologists, their epileptologists, if that's who they're seeing, their family doctor, because we do know that some people don't even get to the neurologist, that they actually just see just their family physician. And so those seizure action plans are available. We have them online. Doctors have them in their office, and they take them and they just sit down and say, okay, we know that at 3 minutes, you need to take your rescue med. Or at 2 minutes, you have to go to the emergency room, things like that. And it just gives all that information.
Okay, thank you. Dr. Holder, I was curious about this. If kids playing sports, if they have epilepsy, are there certain sports they should stay away from? And I'm thinking of like sports like, soccer, because you're bouncing the ball off your head, wrestling, or even football.
Yes, a good question. So, I like my patients to participate in all activities and live a normal childhood. So I generally recommend kids do, be kids and live a pretty normal life. Although I have to say that I'm not sure anybody with a brain should play football. I'm not sure it's safe for any brain. I've told that to a few parents, and it usually takes them a minute to kind of stop and think what I've said. But I think there's pretty good evidence that football probably isn't a great sport for anybody's brain. I don't get too much I don't get asked too much about football, interestingly. Maybe it's because of where I live. I think maybe if I lived in the Midwest, I'd get asked more about that. But, we have to be mindful. So I have some kids who swim. I was actually a swimmer in my first life. And, you think swimming, that could be really dangerous. And, I really want my kids to live a full life and do the things that bring them joy. And you can swim if you have epilepsy. You just have to do it thoughtfully, right? So I was a swimmer and I was a swim coach. And I know that the coach is not watching everybody there at the pool. So if someone does have active epilepsy and they're swimming, somebody has to be watching them, right? We have to make sure that athlete is safe. So as long as that's set up and we know that somebody's watching that swimmer so that they don't have something dangerous happen, I think you can still find a way to participate in sports and make sure that the kids are doing things that they enjoy and then we're keeping everybody safe. So that's a one-on-one conversation that I have with my patients and make sure that we're letting them enjoy their life and doing it in a way that we keep them safe and we keep the rest of the athletes on the team safe and everybody can still do the things that bring them joy. Because I think it's important in life that we do the things that bring us joy, even though we have a chronic medical condition we may be living with.
Okay. Okay, I'm going to be personal, but someone in my family had epilepsy as a child, but as a young adult, he's playing football and has had multiple concussions. So I'm curious, is it possible that those seizures could return? Because he's already had like 2 concussions already playing football.
I mean, it's always possible, but as I said, we have this group of these kind of genetic predetermined self-limited epilepsies, which usually don't come back.
Okay.
So if there was one of those epilepsy syndromes that kind of are outgrown, most of the time those don't come back. But you could also get a secondary epilepsy from the concussions from the football. I have to say, it's one thing that makes me a little frustrated. We're right now in November, which is Epilepsy Awareness Month, which we love. This is our month. And, we're a little behind some of the other awareness organizations. We follow breast cancer awareness, which was last month, which we love them. They do a great job, and usually they wear pink at one of the football games to raise awareness for breast cancer. But honestly, those football players are more likely to get epilepsy than they are breast cancer. We should be doing a little epilepsy awareness at those football games because this is what they're going to be a little more worried about. So we need to get our advocacy a little ramped up here. We're not there yet. We just haven't gotten out to the mainstream population with epilepsy awareness yet. We're working on it, but we're not there.
Mm-hmm. We're working on it, and I can say that there have been some football players who actually have my cleats, my cause,
yes,
that have worn cleats for epilepsy awareness as well.
Yes, they have. Yes, you are so right. Yes. Yeah, we have very strong grassroots organizations in many places, but we just not there yet, right? We haven't gotten the whole country on board for epilepsy awareness.
Well, that actually brings me to my last question of what are some simple steps that individuals can take to raise awareness about epilepsy? And Crystal, we'll start with you.
Simple steps. They can tell their story, share their journey through epilepsy, connect with local epilepsy groups, epilepsy foundations within their state, their local areas. Do little things like now our bridges here in Ohio are purple. Talk about why they're purple. Things like that. Tell their story. And honestly, this is a good step here, bringing it to national Facebook, but don't stop here. Talk about it constantly. Talk about it next week. Talk about it next month. This is November, Epilepsy Awareness Month, but don't let this be the only time you talk about it.
Mm-hmm. Thank you. Dr. Bateman, what can individuals do to create awareness?
Yeah, I think Crystal is absolutely right. Part of the stigma of epilepsy is keeping it in the shadows. Nobody talks about it. And so talking about it is important. And I think anybody can be an advocate. We talk about Epilepsy Awareness Month is this month, but there's also another big epilepsy awareness event called Purple Day, which occurs in March. Mm-hmm. And Purple Day was actually started by a young girl who comes from my home province of Nova Scotia, Canada, who was living with epilepsy and saw a need to raise awareness. And so worked with some of her care team to do that. And now it's an international phenomenon. There are a number of groups led by parents, spouses, siblings, close friends of people who are living with epilepsy who work in the advocacy space. And the more of those people we have, spreading word, spreading understanding, spreading information rather than misinformation, the better off we all are going to be in the epilepsy community.
Yeah.
Thank you. Dr. Holder, do you have anything to add about how else to raise awareness? Because that was a great idea about the wearing purple to the football games.
Yeah. I mean, purple's my favorite color, and it was before I got into epilepsy. So I wear purple most every day. So I agree. I mean, I think it's interesting that so many people, they have misconceptions about epilepsy, and I think when people hear the word epilepsy, they think people with epilepsy can't do anything, that you're not intelligent or competent or capable. And I think that's a lot of the problems we have with people trying to work and losing their jobs, or when someone at work finds out you have epilepsy, even if you keep your job, you suddenly don't get the promotion or the harder tasks or the harder things to do, because subconsciously people think people with epilepsy aren't capable or competent, because there's not enough people out there who have epilepsy talking about it, because the stigma is real. I mean, it's not that they're just afraid they're not going to, the life is going to change. Their life probably will change because the stigma is real, but it's a hard thing to get enough people to want to talk about it to overcome that stigma. But at the end of the day, I think it's the only way to overcome the stigma. So I think Crystal's exactly right. We need to get more people willing and comfortable talking about it, so that we can finally, bring it. The International League Against Epilepsy has had this campaign to bring epilepsy out of the shadows the entire 25 years I've been an epileptologist. And I don't know that we've made it anywhere closer out of the shadows than when we started this campaign. So I think, but, with this rate of 1 in 26 Americans having epilepsy, I really feel that everybody knows somebody, we just don't. But if all of us talked about it, then everybody really would know somebody, and you'd realize that, the person who owns the bakery, or my accountant, or my, the Chief Justice of the Supreme Court, who we all know has epilepsy because he's had 2 seizures since he's been in office. We all know somebody, nobody's talking about it. So I think that's what we really need to just keep working on that way. It'd be so nice if there were more role models for our teenagers and our patients to look up to and say, oh, look, that person has epilepsy, or that person, people that we know who we can use as role models, so that people know that they can have a successful life even with epilepsy. And we're not there yet, but hopefully we'll get there if we all keep working on it.
Yeah, thank you, all three of you. Thank you. This was a great conversation about epilepsy, and everyone in the comments had some great feedback, great questions. So thank you guys as well. For more information about epilepsy, you can head over to blackdoctor.org. There's a lot of articles about many different resources. Wear your purple. And you said that the World Awareness Day is in March.
March 26th.
March 26th.
Yeah, Purple Day. Yep.
Purple Day. So wear your purple, especially that day, but wear it all the time and let people know, because I'm sure there's purple ribbons too that people could get to wear for awareness. So yes, support, get the awareness out there. Thank you again for joining me tonight. This was great. And I
Thank you for having us.
Thank you for having us.
Thank you for having us.
Yeah, have a great evening. Good night, everybody.